Welcome to the Series 3 finale of Diabetes Health Matters. My name is Dr Joan St John and I'm joined by the wonderful Dr Bernadette Adeyileka-Tracz, who's the CEO and founder of Diabetes Africa. And we're going to discuss the wonderful information that we've received throughout this Series 3. This series is sponsored by Eli Lilly and Company, although they have no input into the content of our webinar series. So welcome, Bernadette.
Thank you, Dr. Joan St John. It's a pleasure to be here. It's quite interesting being a guest on your show, but I'm loving it so far.
It's our show, absolutely our show. So I'm going to hand over to you as we run through and recap and revisit those fantastic moments from Series 3 and, all the wonderful information that people have shared with us. So over to you.
Thank you, Dr. Joan St John. As like you said, we've been blessed to have so many fantastic experts with us on the series, sharing tips and tricks and advice for how we can live healthier lives as people living with diabetes, or the carer or family member or healthcare professional caring for someone living with diabetes. And we're going to start off with the fantastic Dr. Isioma Okolo, who's emphasizing the importance of taking the higher dose of folic acid in the lead up to pregnancy, in the first 12 weeks of pregnancy, especially if you're living with diabetes and or obesity. So let's kick off that clip and I'll join you back at the other side to talk a bit more about it.
Once you start thinking about planning for pregnancy, I always recommend for people to start taking folic acid. And if you have type 1 or type 2 diabetes, you should be on a higher dose of folic acid, 5 milligrams. And this you will need prescribed. This you can't get from the chemist over the counter. And the reason for this is this reduces your risk of neural tube defects in your baby. So very, very key thing. Also, no harm in taking folic acid for a year. Your skin and your hair will thank you. Okay? You just have to take a tablet every day, which is a bit of a pain.
And I love that clip. It's not only the benefits to the pregnancy, it's also about our skin, hair and nails, which I absolutely love. But Joan, coming from your experience working as a GP with special interest in diabetes and primary care, how often are you seeing women come in and requesting the 5 milligram dose? Is it something that's widely known, would you say?
No, unfortunately not, Bernadette, and that was why it was so important to stress and emphasise how important taking 5 milligrams of folic acid is. People would tend to go to the pharmacy, so they had that message that they needed to take folic acid if they had become pregnant, but they didn't always get the message that if you're living with diabetes or if you're living with obesity, that you need that 5 milligrams. And the 5 milligram dose is not something you can get over the counter. It has to be prescribed. And the other thing I want to pick up from what Dr. Isioma said was planning for pregnancy. Can we emphasize this enough? Plan for pregnancy. And in that episode, we talked a lot about all the different things you and your partner can do to optimize your health, because if you remember, Isioma was saying it takes two to tango. That was one of the things I remember. Does. Yeah, it takes two to tango. So both of you want to be healthy when you're tangoing, if I could put it like that. You want to optimize your health, you and your partner. So it's those things that you do to plan and prepare for pregnancy. So whether it's lifestyle management, so you're looking after your nutrition, you're looking after your activity, you're looking after your weight, taking the supplements that you need to take, and contacting your healthcare professional, which again is so important. So whether it's your primary care services, so that will be your GP surgery, or whether it's your specialist services, so that might be in the community or in a hospital diabetes service, you need to let them know that you're thinking of becoming pregnant so they can walk with you in that journey.
And add to your points, Joan, I think we've also had some feedback from women who are planning a pregnancy and it didn't happen immediately. If healthcare professionals request for the medication to be stopped, so the 5 milligram folic acid to be stopped, please advocate for yourself and ask for it to be continued, because it's something that, as Isioma said, it's not going to do much harm if you're taking it for a longer period of time. So that aspect is really important. And also speak to your healthcare professional team, because there might be other factors that mean that you need the 5 milligram folic acid as well. So it's part, as Dr. Joan said, it's about that holistic view of planning for a pregnancy. So thank you so much, Isioma, for that fantastic tip. Now we're going to be moving on. It's aligned, like you said, Joan. It takes two to tango. Before we move on to the next clip, for people joining us here this evening, please put your questions and your comments in the chat, and we'll get to that at the end in a Q&A session. And so we're going to be focusing on now men's health. The fantastic Raymond Ladele, who's a GP with special interest in diabetes and obesity, who's going to be talking to us about the importance of open conversations about health between men. So let's hear what he had to say.
He was at a gathering with some of us men. I think it was more like a social gathering, and they were just talking, and one of them just got bold enough to talk about issues in the bedroom, and then all of them looked at themselves, and they're all at that kind of same age group, and all of them like, you too? Oh, me too. Oh, and all of them, it then looked like they all had this problem, but never spoke about it. And I have actually had to help some of these gentlemen in addressing some of these issues, because one person was able to talk about it, and then everybody felt comfortable to talk about it, because it is, at some point in time, for most men, this might be an issue, because most of them have actually ignored the cardiovascular risks they are facing. Many of them had hypertension they didn't know. Some of them had diabetes they didn't know. So I would say that a lot of the time, if we could create programs that are more focused to men.
So yeah, that was Ray making an excellent point about basically how many health challenges might be avoided or solved if we could encourage people to talk about them in a more open way. And I know that can be difficult. Joan, you must have experienced this so many times. Maybe male patients coming in with their partners or their family members to talk about it, or how did you approach this when you were in that setting?
I mean, I think it's a fantastic follow-on from the fertility webinar that we did, and it really crystallized this thing about communication. And okay, we're talking about men's health here and men's communication, but really this is universal, isn't it? But some men find it more difficult to communicate with a healthcare professional about their health. And yes, they can be quite reluctant, and you said that they might be brought in by their partners, and literally sometimes they were dragged in by their partners. And I think one of the things that we emphasise within this episode is about normalising things that might be a bit uncomfortable, a bit sensitive. If you normalise it, then I think people are going to feel more comfortable and more likely to discuss these issues with you. Erectile dysfunction is one of the things that we spent quite a lot of time on, and we make no apology for that. And that anecdote that Dr. Ray said was just so it illustrated so beautifully the sometimes lack of communication until somebody breaks that perhaps stigma and starts to talk about a sensitive topic. There were men together in a gathering. One person decided he was going to mention it, and they all, as Dr. Ray said, were having some difficulties. But once they had actually broached that subject, they were able to get some help for it. And I think that's the important thing. So yeah, we have to normalise it as healthcare professionals. And in a consultation, by normalising it, I think you make it easier for people to talk about it.
Absolutely, Joan. And I think also a layer to add on is that there's cultural aspects to be considered as well, which may make it more difficult to speak up because of views about what it means to be a man and and all that aspect. But you're right, at the end of the day, it's about changing, I guess, our norms, our practices to make it, as you said in the episode with Dr. Lazili, making it normal, like an everyday thing. So I think that's a great point. Thank you so much for that, Dr. Raymond or Ray Ladili. Thank you so much for joining us to speak about that important topic. So next, Joan, we're going to move on to living with diabetes and kidney disease. And the first clip is going to be about an important test that everybody living with diabetes should make sure that they're having done. So important. So now we're going to hear from Dr. Elena Abde-Azeres, who's going to speak more about this important test that everyone living with diabetes should have done.
I always bang on about the urine test because I know, at the population level, we're not doing as many urine tests, and that is a key part of this whole puzzle. So if we haven't got your urine sample, we're not having a full picture of your overall health. So the takeaway message from me is that simple one. When you have your annual diabetes check, please make sure that you have your urine and blood test done. Then from there, I believe my clinician colleagues and all of us in the healthcare can help optimize, treatment options alongside lifestyle changes and, introducing exercise and other things to help you live your life to the fullest, really.
So Elena was talking about the importance of having a urine test done. I think it's more standard for people to think, yes, I have my blood checked to check my HbA1c and my lipids and other aspects. I think it's quite normalised to have a blood test. The urine test, for some reason, when we compare, especially in the UK, the rates of that check being done are much lower, but it's so important. Joan, what do you have to say about the urine test for kidney disease?
Well, we could take this whole episode on the urine test. So there are these 9 key care processes in the UK that everybody living with diabetes should be having on at least an annual basis. The urine test being one of them. But when we look at the figures for those 9 key care processes, the urine test is one of the lowest, always, consistently. And yet, as Dr. Helena so beautifully and succinctly put it, it is so key to us predicting your future health and your current health. It is a really key piece, can I put it like this way, in a key piece of the jigsaw. And we need that information to add to the blood test, to your blood pressure, to your retinal screening, all of those other tests, because that gives us so much useful information. Are your kidneys working the way they should do? Is protein coming through in the urine or starting to appear in the urine? And we add that to the results that we get from your blood test to give us an overall picture of what we call your cardiovascular health. Vitally important. And I think somehow we as healthcare professionals recognise how vitally important it is. The person living with diabetes may not realise how important it is, and that may be why the figures are low. That may be one reason, but us also as healthcare professionals, maybe we're not providing that message sufficiently strongly to say it is key. I really, really need the urine test to be tested so we can predict how things are going with you and discuss how things are going with you. So the other thing is, I think, we have a responsibility to make it as simple, as easy for people to provide that sample as well. Can I get a bit practical?
Go ahead.
The tiny bottles, that we give people. I mean, come on. Each of us would probably know this. We've had this experience at some point in our lives. Those tiny bottles. I mean, it can be embarrassing because how are you going to get the urine into that bottle? Let's, as healthcare professionals, make it as easy as possible for people to provide the sample so that together we can use that information. I think I'll leave it there.
Do you know what, Joan, you are so spot on. I mean, someone could be living in a larger body, they could have mobility issues, they could have dexterity issues. There's so many, they might not be dressed for it at the time. I mean, if you come in with 4 layers in the winter and someone says, oh, in the tiny cubicle that is the toilet, oh, can you come? You are spot on, Joan, absolutely. And I've heard of different, high-tech ways to make it easier. often what we do now is give like a white plastic disposable cup just to make that a bit bigger, then you pour it in. So spot on. And it's so important because it shows a different way that diabetes may, or high blood pressure might be harming your kidneys in a way that can't be checked with a blood test. So it's a very important measure which can't be replaced by the blood test. So let's follow the guidance of the experts and make sure we're getting that test done. Moving on, right, and another, we're just so blessed to have fantastic speakers with us. So we have a psychologist, I believe clinical psychologist, Dr. Sarah, who spoke to us about the psychological impact of living with chronic kidney disease. And I think it's an aspect that is massively overlooked when it comes to long-term health conditions. So I'm really looking forward to going over this clip, and then we're going to come back to Joan to discuss.
So this slide just shows what we call the 5 stages of grief, and it was outlined by initially by a psychiatrist, Kubler-Ross, in a book she wrote in 1969, and it describes sort of the emotional stages experienced when people are experiencing loss. And it was really focused in the context of cancer care. But this can also be adapted to any long-term or any chronic illness, and indeed to chronic kidney disease and end-stage kidney disease.
And I must admit that I've encountered people within the consultation who have been through all of those stages when they have received the diagnosis of chronic kidney disease. And as we've said at the beginning, this can be very impactful on their life. And certainly I've seen people at all of those 5 stages,
Yeah, absolutely. They're very common and very normal. And I think it's important to normalise these stages and not to see them as something strange. And I've just outlined what I call my emotional pathways here. And these are the different stages of the different parts of a journey, of a patient's kidney journey. Again, they may start at seeing their GP, and then when the GP perhaps finds that they've got a blood result that isn't quite right, and they're at stage 4 or 5, then they're sent off to what we call the low clearance clinic here in the UK. And in red, I've got the different types of emotions that people may be experiencing at these different stages. And from GP perhaps into the low clearance clinic, people might be in shock. Again, as from our stages of grief, we saw denial, bargaining. These are all very common experiences and emotions. And individuals can be in the low clearance clinic for several years, and they come regularly. And then their kidney function may decline gradually until a point they'll need dialysis treatment. And sometimes, if it's quite a while, people may become more and more symptomatic. So by the time they start dialysis, they can feel quite relieved, actually, because they just want to feel better. Also, maybe a lot of anxiety, anticipation around the unknown. How will I cope with this? How will this fit into my life, and what will this look like? I'm not going to go through all of the stages, but to suffice to say, I'm thinking about stage 3 here. We call this an unplanned start. There are people who have absolutely no idea that they have end-stage kidney disease, because often it's asymptomatic, and people can remain asymptomatic all the way until they need dialysis treatment.
Joan, I'm so grateful that we had Dr. Sarah's expertise on this, because like I said earlier, I think it's an often neglected aspect of living with a long-term health condition. And I just love your thoughts on what Sarah covered, if you've seen that process in your practice, or just any tips you have.
I think she expressed it wonderfully well, and the slide was so great in illustrating all of those different aspects. Yes, I've seen, as I said to her, all of those different aspects when you give that diagnosis of kidney disease related to diabetes. It may be related to other conditions, but let's talk about diabetes specifically. And it is, I'm going to use the P word, we always talk throughout the webinar series about prevention. And ideally what we want to do is to prevent whatever we can prevent happening by raising awareness, raising information sharing, raising knowledge, so that people can live as healthily as they possibly can. So they don't have that shock, they don't have that grief, they don't have to go through denial. Because, as Dr. Sarah said, kidney-related disease, whether that's due to diabetes or other conditions, can be without symptoms. So it may come as a pretty dramatic shock for somebody to tell you that this is something that is going to affect your health and can be affecting your health for quite some time, as Dr. Sarah said. So, yeah, I think she illustrated it fantastically well with just those 2 slides. But the whole webinar with Dr. Helena and Dr. Sarah was just a fantastic illustration of different aspects of how you might live with diabetes-related kidney disease, how you might prevent it, the things you can do to know if you've got it, and how you can live healthier with it.
Right, so next we're going to be moving on to diabetes in children and young people. And we're joined by the fantastic Davina Jean-Jacques to talk about this topic. Davina is a diabetes specialist nurse in pediatrics.
Now, in a baby, what you may possibly notice, and this is more for type 1 diabetes, because the youngest that we've seen with someone with type 2 is around 8 years old. But your type 1, you're looking at frequent wet nappies. So if you're changing a nappy every couple of hours, every hour, and they're really full, heavy nappies, if the baby is more lethargic and tired, if they're crying and they're irritable because they're thirsty, you're feeding more often, however, they're not putting on weight, really important to kind of seek that medical attention for them, because at that age they can't tell you that they're feeling unwell. So that will be your first sign, is those frequent wet nappies. Okay, we don't want to get to the point of signs of dehydration, which can also happen with diabetes. You can also get more frequent UTIs, so urinary tract infections, so urine infections, thrush and genital itching. You may hear from the school that your child is looking more tired in class, they're not concentrating, their behaviour has changed, because high blood sugar readings can cause children to become irrational, to become a bit more angry and upset. So that's really, really another important one to know, is that diabetes can actually change our cognitive function and behaviour depending on the blood glucose level. So if they're high, you're going to see a behavioural change in your older child. Okay, with type 2, you will have those symptoms, possibly not too much of the weight loss, but it's, I just put a picture up there on kind of the upper right hand side, and it might be important that, you know, if you do see a darkening around your child's neck, under the armpits and the groin area, please also get that checked out, because that is also a sign of insulin resistance. So if you're seeing any of these signs, you can get a GP appointment if you can on the day. Ask them to check a finger prick. That's really, really important. Urine glucose, they're not very accurate. Ask for a blood glucose check. However, if you are seeing some urgent signs of your child being unwell, please go to your local A&E.
Thanks so much, Davina. And do you know why I thought this episode was so important? We know often with type 1 diabetes, but more often now, unfortunately, with type 2 diabetes, children will experience it. And I never actually really thought through in detail what it must be like to try and see the signs of type 1 diabetes in a baby. But obviously it's something that we need to be aware of. Joan, did you see much of this in practice, or do you see much of this in practice, newly diagnosed?
So thankfully, in terms of type 1 diabetes in babies, I didn't ever see in my practice somebody who had developed type 1 diabetes as a baby. as an acute presentation. Obviously, I've seen children living with type 1 diabetes. But one of the best tips I ever heard, somebody shared with me, was the heavier nappies. So, and I just thought that was such a fantastic practical tip, to be alert. As a parent or a guardian looking after children, you sort of get a sense for what the nappy is going to feel like. But if you're experiencing heavier nappies with that baby, then that may be a sign, one of the signs that that baby has or is developing type 1 diabetes. So that was one of the things that had been shared with me, and it was great that Davina raised that as well. With regards to type 2 diabetes in children, yes, I have diagnosed somebody with that, not as an acute diagnosis, but there were those signs that she related. And so you have to have your radar on, because it's not something you're going to see very often as possibly a primary care physician, but you have to have your radar on, because what we don't want is a child either living with type 1 diabetes or living with type 2 diabetes, the first presentation to be that acute, serious presentation of diabetic ketoacidosis, which is an absolute emergency. So as healthcare professionals, keep that radar on, always be alert, thinking about those signs and symptoms.
I absolutely agree, John. I think the 4Ts, the fact that they apply to both type 1 and type 2, but as we know, there's other subtypes of diabetes, and I think the underlying theme is parents know their children, teachers know their students. If something isn't right or not normal for them, is to follow up, and I think that's really important. Okay, right, on to who owns your diabetes? Now, initially when we were thinking about the topic for that episode, we thought, well, isn't that obvious? It's not obvious. But the more and more we heard from people living with diabetes, and let's just say healthcare professionals who have experience, in health coaching, etc., we realized it might not be such an obvious question to answer. So we had the pleasure of being joined by Tonya Oburu, who was going to speak us through the fact that diabetes diagnosis is not the end. So we're going to hear from her now.
I would say what I always say to anyone who walks into my clinic and even online. I always say diabetes is not the end of you. A diagnosis of diabetes does not define you, or it's not the end of you. As long as you have a knowledge and as much as you can, and you're armed with the right information, you can live, to a good age and live well. The most important thing is, there's so many myths and so many things that people are saying online, and that's because complications, yes, might happen, but diabetes does not define you. People feel like their life is over because they've been given a diagnosis of diabetes. Yes, it's not wanted, but having that diagnosis and being armed with the right information would help you to be able to deal with it properly and still live a good life and live well.
I love that point. Yeah. And it speaks back to Dr. Sarah, the clinical psychologist, point about the stages of grief of living with a long-term health condition. I think this point wonderfully links back to that about the emotional impact and the mindset. Joan, what do you think?
Absolutely, and I think that Tonya had encapsulated what we wanted to convey really so beautifully, that it doesn't define you. Any condition doesn't define you. You can decide how you're going to live with that condition, and you can arm yourself, it was the expression that she used, arm yourself with the knowledge to help you to live the way you want to live with that condition. And I think we make no apologies, Bernadette. I mean, each series we've done something with regards to mental health. Yeah. And when I say health, I mean in the holistic way. And also in terms of advocacy, how you advocate and speak for yourself, or how you arm yourself to be able to speak for yourself. And that may be bringing somebody else along with you, is the way that you can advocate. So yeah, I think Tonya encapsulated it really, really well.
Absolutely. And moving on to, so Joan, I laugh, but I mean it in the best way, and it is my motto for life. I just hear your voice saying it. Prevention. We should get t-shirts, we should get hats. But it's so true. The message is so true. And on that point, we have two wonderful speakers who are going to give some key points about how we could prevent type 2 diabetes. So let's kick that off with, firstly, about the importance of sleep.
Yeah. But I think one of the things that people don't always remember that you can do is to try and get some decent sleep.
Oh, absolutely. And so this came from a study that specifically looked at sleep, and they found that it was actually a causal risk factor. So it's not just an association. Getting less than 7 hours sleep per night consistently can increase insulin resistance, and it can also mess up the way that we relate to food. So it can make food less satisfying. So you want to eat more. And when you do eat, the food doesn't fill you up in the same way. And so having maybe a role where you work night shift, maybe you've got small children and you're not able to sleep through the night, being aware that that's a risk factor and trying to address other things or get support with your sleep could really bring down your risk of type 2 diabetes.
Thank you, Dr. Charlene Chonier. Sleep. It comes up as, so we're going to have to talk about it in the next season.
Absolutely.
Because it comes up as a factor in, I guess, every single aspect, like the mental health, physical health, etc. And as Dr. Charlene said, it is not just like a relationship with diabetes. There's more evidence saying that it could be part of the cause of type 2 diabetes. And Joan, I massively respect you because you bring sleep up in almost every episode to keep reminding us. But I guess, what do you have to say about this aspect?
Well, I'd love to have Dr. Charlene's clip that everybody could play maybe about sort of 11, 12 o'clock at night when they're still on their phone. They're still doing their emails, they're still on their phone, they're still looking at social media or whatever, to say, no, this is not conducive to your best health. This is not conducive to optimizing your health. And yes, we're talking about diabetes, but if we're talking about many other conditions, sleep is vitally important. So yeah, I think the only thing I would add is that we need this as a sort of clip that pops up at 11 or around midnight each night on people's social media or their phone or whatever, to say, you need to switch off, you need to wind down, you need to get some decent sleep. That's all I'm going to say.
Do you know how when we were younger they had those campaigns about, look both ways before you cross the road, or like don't drink and drive? I think we need this one nationally at midnight to play.
Get some sleep. Get
some sleep, please. I love it. So thank you, Dr. Charlene. Now we're going to hear from the fantastic Nana Okran, who's going to be telling us about the importance of waist circumference.
The next question she asked me was, Nana, every time I come and see you, you take my waist circumference. You're the only healthcare professional I see who does this. Why is that? Why don't you just use my BMI like everybody else? So I have this slide, this photograph in one of my drawers, and I always bring it out and I say, look, Dr. Charlene talked about it earlier. BMI is only looking at your height looking at your weight based on your height. So as you can see in this picture, the two ladies have exactly the same height, the same weight, the same BMI, but their distribution of body fat or their percentage of body fat is completely different. And Charlene said earlier about where you store your fat makes a difference to how your body behaves. So if, for example, this lady has a lot of fat around her middle area where all the organs are, it can have an impact on her health. So I tend to use waist circumference instead. It's just an easy way of getting a rough idea of where fat is stored in the body. And there's been a lot of research to show that people might lose inches and not lose any weight and still have better cardiometabolic health. So you can improve your blood glucose readings, for example, just by losing fat in the right area.
I love this clip. Yeah, beautifully put. Nana, you are fantastic. I also think that using waist circumference bypasses some of the challenges that we might see with BMI. BMI, body mass index, is not always accepted by everybody because there might be some aspects of how the tool was developed which maybe didn't take into account the diversity of different populations, including people of Black, African Caribbean heritage. As Nana said, someone might have a bit more muscle, or the distribution of fat would be different. So I think it's a fantastic measure. And also, importantly, Joan, I feel like it cuts through some cultural beliefs about weight. I think that in some cultures, I get it. I'm not going to lie, I get it. In some cultures, it's great to be voluptuous. It's good to have nice bottom or chest or whatever. I'm passing no judgment on anyone who that's their preference. But I think unanimously, nobody really likes to have a big tummy. So, Joe, what do you think about that?
So I think that this is something that we've illustrated throughout the webinar series, throughout the series of Diabetes Health Matters. Body mass index is a measurement that's used very often. It's used in pathways, in healthcare, it's used very widely. But we say it's not a very sophisticated tool for giving an indication of what might be going on cardiometabolically, is what the term that Nana used. And what we're talking about what we mean by that rather is your cardiovascular health, essentially. So your circulation, that's going to involve your heart, your kidneys, your brain, all of that. So we want to add a layer of sophistication to that. And the way we do that is that waist circumference, which can determine whether or not that high BMI might be due to living with obesity, or it might be due to being an elite athlete, because you can have a high BMI if you're an elite athlete. The other thing we know is that there is different, what we call cutoff points, different aspects to BMI, depending on whether you're of African Caribbean heritage or some other heritage. So, we need to just unpick body mass index. And Nana gave us a really good road into that using those illustrations. Just those two illustrations were fantastic to show us how we need to discern with BMI, really, and get a bit more sophisticated with it. So it was a great episode to watch and to be part of, because there was lots of tips, lots of information, and all based on evidence as well.
Exactly, I really loved that. And we also had lived experience contribution from Juliana Boyake, who is a fabulous person to share her experience of putting her type 2 diabetes into remission. Along those lines, we're going to be now moving on to diabetes and obesity. And we're going to cover the causes of obesity and also the benefits of even a relatively small amount of weight loss. So let's kick that off with the fantastic Debbie Mozadeki.
The causes of obesity. And remember earlier on we were defining it as a disease. We know that it causes a lot of metabolic issues, and some of those metabolic or lifestyle choices. So when we look at these causes, the most easiest is dietary. We are living in an era of plenty. Okay, so at 3 a.m. if you're up, you can literally Uber some food. There's excess eating, there's excess alcohol intake. We're being told to constantly eat 6-7 meals a day. We are constantly on eating, and we are also bombarded by ultra processed foods, which is not going to be very helpful when we talk about insulin resistance. So again, it's a type of diet that we are exposed to, and our lifestyle, we're very busy, we're very sedentary, and we've got poor sleeping hygiene because we're so busy. We want to achieve so much, we only sleep very little, and sleep is a big component of contributing factor to obesity. And then there's comfort eating. We eat when we're happy. We eat when we're sad. We eat when we meet friends. We eat after work. So that doesn't really help. And then obviously there are some health factors that also contribute to obesity. So if someone has an autoimmune condition and they're put on steroids, that's going to boost their obesity. Someone who suffers from PCOS, or someone who's got low hypothyroidism, that's going to boost their obesity as well. And then there are genetic factors. Now we are in a very exciting era, especially in my department. We do genetic screening because we want to know whether there are fatty genes involved, not because it does give people an aha moment that actually it's not me. I don't have a lack of willpower, but something in my biology is contributing to the obesity. So this slide is really positive. We're talking about positive outcomes. We're talking, it's not all doom and gloom. So what is really important to notice on this slide is that only 5 to 10% of weight loss will warrant a lot of reduction or have positive outcomes on the medical conditions. So you lose 5%, your diabetes already starts taking a backward trajectory, which is really positive, and you carry on, and you might end up in remission, especially with type 2 diabetes. And especially if you've been diagnosed 10 years or less, that tends to go into remission. Blood pressure, again, that tends to take a backward trajectory. We have seen a lot of people, women, that will lose 10% and they were waiting for fertility treatment, and boom, so they lose weight and their fertility goes up and they don't need those the artificial support any longer. So there's a lot of positive outcomes from just losing 5 to 10% of one's weight.
And big question here. Okay, first of all, let's say, you're 11 stone, about 70 kilos. You lose 7 kilos, 10%. You lose 3.5 kilos, half a stone, equivalent. You're still going to get some major benefits.
Absolutely.
It sounds wonderful. It sounds great. How do you do it?
Okay, that's where you and I come in later on. But it is possible, and we just want to let people who are listening that it is possible, and it's not all despair. There is hope, and once you see, the brain works on reward system. Once you see that little reward, you see your diabetes figures going down, it rewards you to keep going. And we can talk about some of the ways you can lose weight. Yeah.
Excellent, thank you.
I love those points, Joan, honestly, because I think there's been more and more awareness about the causes of obesity, the fact that lifestyles can make it difficult, as in shift work, long hours. A lot of people have multiple jobs, stress, young children, etc. The list goes on. And then sleep, as we mentioned before.
Yes.
That can make this more challenging. And of course, there's a genetic aspect. You can see even among siblings. Some have a very slender physique, some are built differently. But then on the positive of how, if you are living with obesity or even overweight, that 5%, which still is, I think can be still challenging to do. That's not undermine how difficult that could be, but it can have a positive effect for both diabetes and other related diseases.
There were so many important messages from that episode. Number one, World Health Organization, obesity is a disease, and recognizing that, which may be a bit of a change for some people, recognizing that it is actually recognized as a disease. So that was one really important thing that came very loud and clear from that episode. And the causes, those multifactorial causes that people may be experiencing, which may make them live with obesity. But that positive message at the end, that 5 to 10% weight loss, total body weight loss, can make such a difference to their overall health. So particularly with diabetes, type 2 diabetes, may be able to put that person's diabetes into remission, particularly if they're early on in that journey of living with type 2 diabetes. But you're going to get some health benefits. You're going to get, other health benefits, even if remission doesn't occur. That is not the only thing. Really great episode to get lots of information as a healthcare professional, as a person living with the disease, as somebody who is within a family of somebody who is living with obesity as well.
Mm-hmm. Absolutely, Joan. And going back to your 3 Ps, mm-hmm. I think it's also, like we said, and this, I guess the speakers have said throughout the highlights, about how little changes over time can be for good, and how it can prevent other complications. So I think, I love the positive message that we ended on. Right, to one of our most popular topics, because it is so much of our culture, our heritage, our everyday. It's parties, it's everything.
It's life.
Food. It's life. It's food. And I know I definitely enjoy my food. Definitely. And I know many others do. So it was so popular that we did 2 events in this series about food. We're going to kick off first with Jasmine Carbon of Carbon Nutrition. She's a registered dietitian. She also works in the NHS as a dietitian. So the first point we're going to speak about is how we can address the carbohydrate dominance that we often see in our foods. And then we're going to hear about glycemic index as well. So let's hear from Jasmine.
Wanting to see, on the one hand, what can we do about the tendency we have to have a carbohydrate-rich diet when we come from Africa or come from the Caribbean. And the other thing is about how you can make your rice healthier. So the things that you can do to maintain rice in your diet, because, that is one of our staples. But how can you make it healthier? So you've said adding some sort of protein, so like rice and peas, for example, as opposed to plain rice, because you're having less of the rice and you're adding in a protein source, which will help with your glycemic index, so the way that glucose is absorbed by your body and the rate at which it's absorbed by your body. And also it looks like it's fuller on your plate, if I can say that to a dietitian, because that's important to us as well. But that's one of the ways. Portion sizes presumably is another way. And sort of mixing it up, having different things from the different food groups also is one of the things, yeah? So to those 2 people, that was something that was really important for them to find out. How can we make rice healthier? Not have to give it up. And also, how can we tackle our tendency to have a lot of carbohydrate in our traditional diet, but keep our traditional diet, but keep it healthier?
And then when we take kind of glycemic index, so that's essentially a number given to foods to kind of measure its response measure our body's response to that food when we compare it if we'd had just pure sugar or pure glucose. So if a food has a higher glycemic index, that means that that food is absorbed or broken down very quickly, and the glucose can be absorbed very quickly into the bloodstream. If a food has a low glycemic index, it's the opposite. It's a slow breakdown, it's digested slowly, it slowly raises blood sugar. So the types of foods which are going to have the lower glycemic index are going to be foods which have got a bit more fibre in it. So they tend to be less processed. And they might also be be in combination with kind of fats or proteins. And this is where we can start to think about glycemic load. So glycemic load is our body's response to food in relation to the glycemic index of the food, the GI, but also kind of what else you have with that meal. So have you also taken, is that meal or food also in combination with fats or protein? So we can take an example of something like watermelon, or fruits in general, which tend to be have a high GI because it's broken down really quickly, but then it will have a low glycemic load because there's nothing else kind of within that food help kind of slow down the process of it being broken down and absorbed into the body.
Thank you so much, Jasmine, for taking us through those points. I think, Joan, you've already addressed the first one eloquently, which is about how we can address the carbohydrate dominance in our food. You mentioned about preparation, portion sizes, if we can swap some things out potentially. And I don't know if you have any comment on that, and also the glycemic index.
Yeah, I think, it's something that crops up quite often, and that's why we did the 2 episodes. And we will keep revisiting it because it is something that people have a lot of questions about. So yeah, we talked about, it's our staple. Rice is one of our key staples. So let's find a way to make it healthier. And yeah, all the things you said, Bernadette, the portion sizes, adding in the protein, how you cook it, all of those things to maintain our traditional foods. And I think it was really important for Jasmine to show the glycemic index and also to talk about glycemic load, because these are terms that might come up and people wouldn't necessarily have an understanding of them. But throughout the Diabetes Health Matters resource, you can pick up all these things, you can pick up all this information. So whether it's glycemic index, whether it's glycemic load, whether it's about how to make our traditional foods healthier, if you're living with diabetes, all of those things are there.
Absolutely. Thank you, Joan. And moving, another absolutely fantastic speaker, Dr. Shola Oladipo, who's going to be talking about our African and African Caribbean foods and how we should feel about them, and then also an overview of some of the foods from across the regions.
We're not a monolith, we're not a homogenous group. We are indeed a global majority, and actually there is nothing wrong with our foods. Dr. Joan, can I just say how tired I am? People, saying that there's something wrong with our foods. I'm actually hearing, our communities who are living with chronic illnesses like diabetes, feeling that they can't actually eat our foods. What a tragedy. People are sacrificing because they really feel there's something wrong. And just to reiterate what's already been said, there's nothing wrong with our foods across the continent of Africa and across the somewhat 30 or more beautiful islands of the Caribbean. We are blessed with a plethora of foods, ground provisions, and there's nothing wrong with them.
There is absolutely nothing wrong with our foods. And yeah, enough said.
Enough said. Moving on.
Yeah, we've got good old agege bread, very popular across Africa. Actually originated by a Caribbean country, Haven Universities, and developed this sweeter type of bread, very similar to hardo bread, a bit lighter but very similar, as a solution to something that he could enjoy. And it's taken off in Nigeria as agege bread. As we can see, it's a little bit, it's a little bit denser than our typical sliced bread, but again, it's not off the scale. It's something that we can enjoy as part of our healthy eating.
Looks very much like hardo bread, actually. Yeah,
it really
I
does.
think it's an acculturation, isn't it? Really?
Yeah. Yes, indeed, indeed. Oh, plantain chips.
Oh my goodness.
Indeed. Nothing is outlawed. It's just about understanding carbohydrate. They're quite high in fat as a snack. The nutritional breakdown we've shown here really depends on the brand. So there are quite a few brands in the UK at the moment, but it's just about understanding this. It should be something that we have less often.
And I like the way you said about the nutritional content, because you can get green plantain chips, you can get plantain chips, you can get salted, you can get sweetened, you can get not sweetened. Trust me, I've seen a lot of the packets. So yeah, check the back of the packet. And as Shola said, it's a treat, not something to be having perhaps regularly.
Another favourite, Dr. Jones?
Yep. Okay. And I think, so carbohydrate content is nearly double, I think, from what the oxtail and rice was. Why? Because maybe you've got a bit more rice and peas there. Also, you've got plantain, because the plantain is going to be forming part of your carbohydrate content as well as the rice and peas. looks absolutely delicious. How could you make it lower in carbohydrate? If carbohydrates are an issue to you, if the rise in blood glucose is an issue to you. So some people, don't shoot me, some people roast the plantain instead of frying it. It's a possibility. You can do it. You can still get it with that nice sort of crispy texture, like fried, but it's not been fried. You could reduce your portion of rice and peas. Not seeing any veg on there. So reduce your portion of rice and peas, add in some veg, add in some green veg. Make it healthier, but eat the foods.
Yeah, absolutely. And that chicken, hopefully we're doing that chicken in the air fryer as well. Comes out nice and crispy. We could lose the skin if we were feeling very generous. And it tastes just as lovely, actually. Ooh, one of my favourites.
Delicious. Oxtail and rice, yeah. Mum and hubby's favourite. Yeah, as you said, moderate carbohydrate content, because if you look at that meal, if it was on a plate, about a quarter of that would be the carbohydrate. So, and as you said, it's like a fistful of carbohydrate on that plate. So that's why the carbohydrate content isn't as much as you perhaps would think. But that looks like a delicious meal.
It looks amazing.
Yeah, you've got your salad, you've got your veg there, and you've got your oxtail. So yeah.
Have you seen the price of oxtail recently, though? Moving on swiftly.
It's fine. It's occasional. I don't.
Indeed, that will make it occasional.
My goodness, Dr. Shola Oladipo, Food for Purpose, Dr. Joan St John, you guys are so good at what you do. I was giggling and cackling through that whole thing. Dr. Shola, I'm sorry, I'm not taking my skin off my chicken. No, let's just say these are tips and advice for people to follow. Not every single thing we have to do, but absolutely fantastic as always.
Yeah, so I mean, as I said at the end, it's about giving you that information. So Bernadette, you can make the choice as to whether you take the skin off the chicken or you're going to leave it on. But yes, it's giving everybody that information so they can be empowered to make those choices for their own health. Yeah, for their own health. What is it? Where's your red lines? Bernadette's is the skin on the chicken. But for other people, it might be somewhere else. So yeah, it's about giving that choice. Giving the information.
Absolutely.
That choice.
And about moderation, like you were saying, Joan.
Yeah, portion size is, really, really important, but vitally important. Dr. Shola said it. I've said it. We've all said it. Our traditional foods, there is nothing wrong with them. Yeah, let's find out how we can be healthy with them, but there's nothing wrong with them.
Preach. Absolutely, absolutely. And life wouldn't be life if we couldn't have our cultural foods as part of our diet.